So do GPs and RNs collaborate in general practice? Well, that's been the focus of my research, and I'm going to be presenting some of the findings of this to you today. Is that going to go? Oh, wrong one. There. Sorry, I'm right with it now. So just a very brief background to some of the issues influencing the general practice workforce. Oh, far out. Well, at least I didn't use any language. I'll put it down there and it's out of my hand now. So just a brief background to some of the issues influencing the general practice workforce. We saw on the APNA website only just recently that Australia is expected to experience a shortfall of 27,000 primary healthcare nurses over the next decade. And on top of this, the supply of Australian general primary care services are projected to exceed the supply of GPs. This is partly because of our ageing population, and the early discharge from hospitals is increasing the level of chronic and complex illness treated in the community. And at the same time, the latest and probably last Beach report also explains how more Australians are presenting to general practice for complex treatment and advice than ever before. So why specifically collaboration? Well, in an era of professional healthcare shortages, improving the way that GPs and RNs collaborate may facilitate the building capacity of the general practice workforce and strengthen the delivery of primary care services. Now, collaboration between health professionals has been shown to improve the coordination of care, enhance workplace satisfaction, decrease healthcare costs, which in terms of privately run enterprises is very important. But most importantly, collaboration has been shown to improve client outcomes, and I think that's why we are all here. Now, people often describe collaboration and teamwork as interchangeable concepts, and both certainly share common characteristics around shared responsibilities, decision-making, goals, the need for open and honest communication, and trust and respect. However, the two do comprise subtle differences around leadership, hierarchy, and autonomy. And that is, working in a team requires a team leader. And there's often a tendency for teams to work autonomously and in parallel to each other. A collaborative environment, however, tends to be non-hierarchical, and team members may experience less individual autonomy, but that's because team members tend to be more interdependent. So the aim of this project was to explore the nature of collaboration between GPs and RNs working in general practice, and to see if this unique work environment supported them to work collaboratively. So I'll just briefly go through the design and methods. So this was a qualitative project using a naturalistic design, and that basically meant that I went into the participants' natural setting and I used individual face-to-face interviews to gather the data. However, before I did do anything, I did gather ethics approval from the university's Human Research Ethics Committee. And both GPs and registered nurses were included. RNs were specifically targeted because they comprise the largest proportion of the workforce in general practice, and I think it's about 82 to 83% of all practice nurses are registered nurses. And nurse practitioners were not included because they comprise only about 0.3%, and they've also got a wider scope of practice, and likewise enrolled nurses were not included because of their narrower scope of practice and the number of them that are actually in the workforce, which is about 12%. So 2 primary health networks in New South Wales were the focus of this project, and they were the South Western Sydney and the South Eastern primary health networks. And recruitment included city, metropolitan and rural practices, and solo through to large group practices. And practices were emailed an information sheet about the study, and they contacted me if they wished to participate. And I also placed recruitment advertisements on the APNA website and the Primary Health Network websites to further explain the study. Semi-structured interviews were conducted by myself, and all interviews were transcribed verbatim by a professional transcription company. And I think you've seen me with technology here. I'd still be typing if I had to do it. So transcripts then went through a process of thematic analysis, which involved the reading and rereading of transcripts, looking for meaning and patterns in the data until codes and themes started to emerge. And as a team, we discussed the potential themes until consensus was reached. And I'll just point out here that The team comprised of myself and 3 supervisors, 2 of which are academic nurse researchers with extensive experience in general practice research, and one of them I think is here, Liz Halcombe, so thank you Liz for putting up with me. And the other is an academic general practitioner, so he actually helped provide a really good balance to the team, having RNs and a GP on board. So I'll just briefly go through some of these demographic findings. In total, I conducted 22 interviews. 8 were with GPs and the remaining 14 were with registered nurses. And I really can't begin to tell you how thankful I was to have this kind of response, because the private nature of general practice and the busyness of general practice actually makes it really difficult to recruit participants into this kind of research, and I was very thankful to all those that did volunteer. So participants were recruited across 13 practices, and I travelled a distance of just over 2,100 kilometres to conduct the face-to-face interviews. And all participants felt they collaborated well, and that the goal of collaboration was to improve client outcomes. And most did not see the difference between collaboration and teamwork. So there were 3 themes that were generated from the data, and I'll discuss each one in a little bit in detail shortly. The first was around the influence of funding models on collaboration. The second was around understanding the registered nurse's role, and the final theme was around the facilitators and barriers to collaborative teamwork. So first theme, the influence of funding models on collaboration in general practice. This theme developed a little bit left of field, so just to put it into perspective, most general practices in Australia operate as small business enterprises, and I know that that is changing, but that's what it is at the moment. And income is largely generated via tax-funded fee-for-service arrangement, more commonly known as Medicare. And other income is generated via client co-payments and incentives such as the Practice Nurse Incentive Program, or PNIP. Now, where funding and collaboration become intertwined, or perhaps more correctly diverged, was through the different perspectives of GPs and RNs when it came to the timely delivery of care. Remembering that collaboration, amongst other things, involves a shared understanding, shared responsibilities, mutual goals, and clear and open communication. However, as this slide shows, GPs largely perceive that the only way that you can fund a nurse's time is by hoping that they make the GPs more efficient. So this perception doesn't establish a collaborative framework from which to work. Whilst GPs certainly acknowledge the contribution RNs make to client care, it was apparent that many valued RNs in terms of increasing their own efficiencies, rather than as a complementary health professional providing quality nursing care. As this next slide indicates, RNs often felt pressured to generate income, and that this could impact the care delivery and the way they worked with GPs. So the GPs say, well, you need to get good at saying, well, we'll deal with this now, you need to come back for this and that. But unfortunately, if I don't deal with everything at once, then they may give up. So despite understanding the financial constraints of private practice, RNs felt compelled to take time to respond to the needs of their clients, rather than to prioritise short consultations that would enhance remuneration to the practice. There is no presumption here that the GPs were not equally concerned with client welfare, only that there wasn't a shared perception on how this should be achieved. It was also evident that whilst GPs referred to the nurses' knowledge in their areas of expertise, the majority felt a need to co-consult and have input into each client's care. This appeared to be driven by a perception of liability and remuneration that this brings to the practice, rather than as a form of collaborative care. As is evident in this slide, the practice of co-consulting was a consistent source of contention and clearly frustrated RNs who perceived this to be a duplication of services and an inefficient use of time, and showed little evidence of shared care. So, I mean, to have a doctor come in and tell you how to steri-strip a skin tear, or dress a wound, or dress a burn, it's a waste of their time, and the nurses could just get on and do it. So there was this repetitive concept that funding structures limited the nature of collaboration between GPs and RNs. On one hand, the GP acknowledged the RN's expertise and certainly sought their advice, and on the other hand, there was a perception of having to have input into that care that was clearly within the RN's scope of practice to deliver. There was also a perception amongst GPs and that RNs can be a financial burden to the practice. And this was evident when RNs were compared to the cost of employing a GP trainee for the same price. However, considering the benefits of each based purely on remuneration did not account for the different types of clinical input that each could bring to the practice. And without resolution, employment stresses around funding and remuneration did reveal the potential to increase the turnover of nurses. So the second theme was around understanding the registered nurse's role in general practice. As previously stated, collaboration requires a clear understanding of each member's role. However, as is evident in this slide, it was apparent that GPs did not always have a full appreciation of the RN scope of practice, and this limited collaboration and the nurse's role within the clinical team. So sometimes, on rare occasions, we might get nurses to actually talk to patients about quitting smoking or just general dietary advice. This lack of understanding meant that GPs were reluctant to have RNs talk to clients regarding education and lifestyle risk factor modification, both of which are well within their scope of practice and would again appear to limit the contribution RNs can make to shared client care. And perhaps the greatest contributor to the GP's lack of clarity around the RN's role were the number of participants who cited generic or basic job descriptions. And as this slide shows, there probably is a job description somewhere, but I don't know whether I've ever laid eyes on it. Now, job descriptions are a component of practice accreditation, yet in the absence of well-defined job description, nurses were often aggregated into a single category regardless of their qualifications. And narratives revealed how generic job descriptions did little to promote interdisciplinary awareness, and in fact they exacerbated role ambiguity and role blurring and decreased the utilisation of RNs. However, a willingness for GPs to openly seek and discuss the nurse's scope of practice facilitated an understanding in their role, and this was viewed as a positive move towards collaboration. So, as this slide shows, many RNs describe their role as ancillary and supportive to the GP. So part of my job is to look at the doctor's schedule each day and see what I can do to help them. And again, this did not promote a collaborative environment and appeared to negatively influence the RN's sense of professional identity. And the delegation of tasks by GPs also did little to develop the RN's role or their position within a collaborative team environment. Indeed, it was evident that the delegation of tasks could limit collaboration when responsibilities, decision-making and patient goals weren't shared. And this was perhaps best explained by another RN who said, "I don't know what's wrong with these patients unless the GP tells me for some reason." So the third theme was about working together as a collaborative team. I have never felt in this practice that I'm just the nurse. It's very much what we do in the practice. It's the GP's practice, but he refers to it as our practice, our patients. And as this slide shows, narratives that generated inclusive language evidence a productive and non-hierarchical environment which fostered collaboration between GPs and RNs. Now, communication was also consistently articulated as a driver of good collaboration. However, the framework within which communication occurred was a constant source of disparity between practices. And I'm not sure if you'll be able to see this at the back, but I'll nip through them. So ad hoc informal doorstop meetings and instant computer-aided generated pop-up messaging, followed by phone and email, were the most frequent forms of communication used by participants. Whilst these informal patient-focused discussions serviced the immediate need of the client, they did little to promote collaborative decision-making. Participants also reported that whole staff practice meetings were irregular and varied from none to biannual. 5 practices reportedly held clinical teaching sessions with GPs, RNs and local allied health professionals. However, regularity of teaching sessions varied from infrequent, such as post-conference, to regular 1-hour weekly sessions. RNs were mostly invited to to attend these teaching sessions, but not always. And only one practice evidenced collaborative teaching by inviting RNs to present at such sessions. And one practice reported holding daily clinical team meetings to discuss client care. Now, reasons for not conducting daily clinical meetings included logistics, meetings being a monumental waste of time and no need. However, the practice that did conduct the daily clinical meetings perceived them to be vital in providing a coordinated approach to client care. The team meetings were non-hierarchical, promoted interprofessional respect, increased staff satisfaction, and ensured that both GPs and RNs commenced the day with a shared understanding of client needs. So we look at the list, who's coming in, who we saw yesterday. We talk about who we saw yesterday and what we're struggling with, what we're going to do about this, what happened the last time they came in, or just be careful of this, that and the other thing. So we call that a team meeting and we use that, and the nurses are invaluable. And this GP went on to explain how team meetings were instrumental in developing trust in the RN's competencies and understanding of their scope of practice. This was largely because the GPs could hear firsthand what the RNs were saying in relation to client care and therefore knew what level they were functioning at, and they trusted their judgment. Now, interestingly, whilst participants sought to share each other's expertise, most practices adopted a parallel model of care. As this example shows, the majority of participants described the GPs as responsible for the diagnosis and management of client conditions, and RNs as broadly responsible for clinical tasks, lifestyle counselling and liaising with allied health teams. This parallel model of care placed the GP as the team leader and was actually liked by RNs who felt it enhanced their own autonomy. However, in actual fact, it did limit collaboration, as there was little evidence of shared decision making or that interaction around shared goals. So, just in conclusion, this project actually found little evidence that the dominant fee-for-service funding model in Australian general practice encouraged or rewarded GPs and RNs to collaborate, largely because it promoted the co-consultation of clients rather than the co-coordination of client care. And whilst practising at the top of your licence is becoming an important issue, it is apparent that many GP participants lack clarity around the RN's scope of practice, and this limited collaboration and the RN's role within the clinical team. And at the same time, many RNs articulated their role as an assistant rather than as a complementary health professional. And finally, it is clear that whilst communication is an important feature of collaborative teamwork and is in fact woven throughout all themes, the way GPs and RNs communicate is not always productive. However, a non-hierarchical environment which uses a synchronous model of communication, such as the clinical team meetings, promoted interdisciplinary awareness and supported RNs to work to the extent of their practice and promoted collaboration. So to ensure the sustainability of nurses in this setting and the optimisation of their role, consideration needs to be given to the ongoing financing of the nursing and general practice workforce. Practical modifications identified in this research do not entail training or expenditure and may be adopted relatively effortlessly. And this is important in terms of operational costs of small business enterprises. And implementing these strategies, particularly those which clarify the RN's scope of practice and encourage formal clinical discussions between disciplines, has the potential to improve collaboration between GPs and RNs and to maximise the RN's role within the clinical team. This may enhance staff retention and improve operational efficiencies while supporting positive client outcomes. Thank you.